We've all felt it, right? That instant sharp jolt when you stub your toe, or maybe that persistent kind of weary ache from an old injury, pain.
Mm-hmm.
On the surface, it seems pretty straightforward, like a simple signal from your body saying, hey, something's not right here. But you scratch below that surface, and wow, it reveals layers of incredible complexity.
Yeah, much more complex than just that basic alarm system we often think it is. It's fascinating, really.
Exactly. And that's our mission today. We're doing a deep dive, sort of cutting through the density of this stack of source material you've shared, clinical guidelines, research findings, stuff like that.
Right.
We want to pull out the absolute most important nuggets of knowledge just for you. Think of it as the essential insights delivered without you having to do all the dense reading.
We're basically here to help you understand what truly matters in these sources about how we understand and treat pain today.
Okay, let's dive right in and unpack this. First, at its most fundamental level, our sources describe pain as profoundly subjective.
Yeah, that's key.
It's not just a sensation. It's an individual experience you learn to understand based on your own personal history with, like, tissue damage.
Yeah.
Your perception, your interpretation, that's central.
Right. And if we look at the basic mechanics, the plumbing of acute pain, the kind that comes with the injury, it starts with pain receptors. They're called nociceptors.
Yes, receptors, okay.
Yeah, they're found all over your body, and they get activated by chemicals released when tissue is actually damaged.
And the signals from those receptors travel along different kinds of nerve fibers,
Yeah.
which is why we get those different sensations. Is that right?
That's exactly correct. You have the thinner, slower C fibers. They carry the message for that dull, burning, or aching kind of pain. And then there are thicker, faster A delta fibers. They're responsible for that immediate, sharp sting you feel first, the ouch moment.
So the signal starts at the injury site, goes up the spinal cord, and eventually hits the brain. But here's where it gets really interesting. It's not just a simple, direct highway.
Not at all. The signal gets modulated, you could say, influenced at multiple points along its journey. Right there at the injury site, in the spinal cord, and up in the brain itself.
Okay.
And what's fascinating, what these sources really emphasize, is that this modulation largely determines where and, crucially, how intensely someone actually experiences the pain.
And there's a whole cast of chemical characters involved in this modulation, this turning up or down of the signal.
Oh, yeah. A whole soup of them. Some substances like histamine or serotonin, they can dial the pain signal up, but then your body's own natural pain relievers like endorphins or enkephalins can dial it down.
Nature's painkillers.
Exactly. And there are many others involved too. Acetylcholine, noradrenaline, dopamine, GABA, glutamate, substance PEEP. It's this incredibly complex chemical balancing act.
Which really brings us back to that subjectivity point, doesn't it?
It does. And it highlights another crucial insight from your sources: how much psychological, social, and even cultural factors profoundly influence this entire process.
So they're not just side effects of the pain, they actually shape it.
They shape your perception threshold, how you interpret the sensation, even how you express it. Interestingly, the sources do mention a finding that on average, women tend to report a lower pain threshold, experience pain more intensely, and use pain medication more often than men.
That observation alone really underscores just how personal and multifaceted pain truly is. Okay, now let's talk about a major shift. When pain becomes chronic. This is where the story of pain seems to take a fundamentally different turn.
Yes, a really different turn. Chronic pain is defined as persistent pain, sure, but it's described in your sources as much more than just pain that lasts a long time. It's seen as a multifactorial health problem.
Multifactorial how?
Meaning physical, psychological, and social factors are all intertwined. They influence the pain experience itself, the person's behavior, their quality of life, and crucially, the diagnosis isn't based solely on how long the pain has been there.
So the key difference compared to acute pain is that the direct link to the original tissue damage starts to weaken. And the pain signal isn't really acting as that simple, stop doing that alarm anymore.
Precisely. That's a great way to put it. Even if it started with an acute injury or maybe a chronic condition like osteoarthritis, in chronic pain, those psychological and social factors take on a much, much larger role in actually driving the experience.
And one of the most probable explanatory models for this shift, according to the sources, is something called central sensitization.
Right, central sensitization. This involves actual changes happening in the wiring of the central nervous system itself, so in the brain and spinal cord neurons and their connections.
The system becomes hypersensitive.
Essentially, yes. The pain signal gets amplified, and it becomes less and less dependent on whatever the original physical stimulus was. The volume knob gets stuck on high, you could say.
So what does this sensitization look like in practice? What are the consequences for the person experiencing it day to day?
Well, the relationship between the pain they feel and any initial tissue damage becomes much less clear, much fuzzier. They might start experiencing pain without any obvious trigger at all. That's called allodynia.
Like pain from just a light touch.
Exactly. Or the pain might be far, far stronger than you'd normally expect for a particular stimulus that's hyperalgesia. And sometimes the pain can even spread beyond the original injured area, which is called secondary hyperalgesia.
And this is where those biopsychosocial factors we talked about come back into play again, isn't it? Things like stress or anxiety actually influencing this hypersensitivity.
Absolutely. Your psychological state, stress, anxiety, maybe even how reassured you feel or how distracted you are, your social support network, your beliefs about the pain. These aren't just side issues. They actively influence these sensitization processes in the nervous system.
Right.
And they can maintain the pain cycle even if the original physical cause has maybe resolved or lessened significantly.
That really flips the traditional understanding of pain on its head, doesn't it? It's not just in the body part anymore.
It's in the system. And your sources list several risk factors for developing chronic pain or for it persisting, and they really highlight this biopsychosocial aspect.
What sort of things are on that list?
Well, beyond physical factors like, say, high initial pain intensity or pain that keeps coming back, the risks include behavioral things, like avoiding physical or social activities because of the pain.
Fear avoidance, yeah.
Right, or maybe not properly treating the acute pain in the first place, or not following normal recovery principles. Then there's chronic stress from life stuff, job loss, finances, relationships. Psychiatric issues like anxiety, depression, PTSD play a big role.
And thought patterns, too.
Definitely. Negative thought patterns like catastrophizing, thinking the worst will happen, believing the pain is only physical and there's nothing else going on. Even things like inadequate social support or maybe too much solicitous concern from others can paradoxically maintain it. Assessment or legal procedures can even become risk factors.
So it's really about the whole person and their entire life context, not just the bit that hurts. Okay, shifting gears slightly, let's talk about different flavors of pain. Your sources mention neuropathic pain specifically.
Yes, neuropathic pain. This is pain caused specifically by damage or disease affecting the somatosensory nervous system itself, either the peripheral nerves out in the body or the central nervous system, the brain and spinal cord.
So it's a problem with the wiring, not just the signal from tissue damage.
Exactly. Think of it as the nerve itself being the source of the problem.
And that's distinct from the central sensitization we just discussed.
It is distinct in its origin, yes. The trigger is nerve damage or disease. However, central sensitization can definitely contribute to maintaining neuropathic pain once it's established. The two can coexist and interact.
So how do you spot neuropathic pain? What does it typically feel like for someone?
Well, the characteristic symptoms often include a constant background pain that's described as gnawing or burning.
Okay.
And on top of that, you might get sudden shooting or stabbing flare-ups, like electric shocks sometimes. You'll usually find sensory changes in the area supplied by that affected nerve, maybe numbness, but often increased sensitivity.
Like that allodynia again? Pain from light touch.
Precisely. Allodynia is common. Sometimes there are also autonomic changes, differences in skin temperature or color in the affected area. Now, while it should theoretically follow predictable nerve pathways, the sources note that, in practice, the connection between where the pain is felt, the stimulus, and the actual severity or location of nerve damage isn't always clear-cut.
So it can be tricky to pin down. How do clinicians even screen for this, especially, in a busy acute setting?
Your sources suggest asking some specific screening questions. Things like, is the pain burning? Does it involve tingling or prickling sensations like pins and needles? Is there reduced sensation to touch in the area? Is the pain worsened by light rubbing?
Okay. Direct questions.
Yeah. And there's also a specific tool mentioned, the DN4 questionnaire. It's basically 4 questions that break down into 10 yes-no items. If you get 4 or more yes answers, it strongly suggests neuropathic pain is likely involved.
That sounds like a practical way to flag it up, at least.
It is, although the sources do caution that distinguishing neuropathic pain from pain primarily driven by sensitization processes in someone with chronic pain can still be quite difficult sometimes.
Right, because they could overlap. Now, given how subjective pain is, how we started this whole conversation, how do we even measure it or assess it effectively?
Yeah, assessment is absolutely crucial. because it gives everyone involved, the patient, the clinician, the whole team, a common language. And importantly, a way to track changes over time. Are things getting better, worse, staying the same?
So things like pain scales.
Exactly. Simple pain scales are invaluable, like the numeric rating scale, rate your pain from 0 to 10, or for younger kids, over about 3 years old, the FACES scale can be really helpful.
What about physical examination? Can observing someone tell you much about their pain?
It can, yes. Observing pain behaviors, especially during movement or specific activities, can be very insightful, particularly, as your sources note, in vulnerable patients like the elderly who might struggle to articulate their pain clearly.
But physiological signs aren't always reliable, like heart rate.
Much less reliable, especially for chronic pain. Your sources caution against relying heavily on things like heart rate or blood pressure to gauge pain intensity. These physical signs are often absent in chronic pain, and their absence certainly doesn't mean the person isn't experiencing significant pain.
Right. That's important. And for chronic pain, assessment isn't just about hunting for a single physical cause, is it?
Exactly right. Any further investigations, like scans or tests, need to be integrated into that broader biopsychosocial approach we keep coming back to.
Hmm.
You're not just looking for tissue damage, you're also systematically evaluating those physical, psychological, and social factors that are contributing to and potentially maintaining the whole pain picture.
Which naturally leads us into talking about treatment. With all this complexity, it's pretty clear a single magic pill just isn't going to be the answer for most people, especially with chronic pain.
Definitely not. A multidisciplinary approach, really grounded in that biopsychosocial model, is highlighted in your sources as essential for improving outcomes.
So different professionals working together.
Yes, involving various healthcare professionals, maybe the GP, relevant specialists, a physical therapist, perhaps a psychologist, all collaborating. This teamwork generally leads to better results.
And medication is just one piece of that puzzle, right? Not the whole solution.
Exactly. Non-medication strategies are incredibly important, particularly when pain is chronic or looks like it's at risk of becoming chronic. Education's huge, explaining the nature of pain, especially the chronic type, and the idea of central sensitization is a vital first step for the patient.
Helping them understand what's happening.
Yes, and then actively addressing those psychological and social factors we identified as hindering recovery. Things like stress management techniques, challenging unhelpful beliefs about the pain, improving coping strategies. For musculoskeletal pain specifically, physical or exercise therapy that focuses on getting the patient activated again, moving appropriately, and providing coaching is often a cornerstone.
But medication does still play a role, particularly for acute pain, maybe to help prevent that shift to chronic pain.
Precisely. Discussing medication options is key because untreated or poorly managed acute pain is itself a risk factor for developing chronic pain. The general principle, which echoes the WHO pain ladder approach, is to start with the simplest, least potent medication that's likely to be effective and, crucially, has the fewest side effects.
And you need to check if it's actually working.
Absolutely. You need to evaluate its effect with the patient within a realistic time frame that you both agree on beforehand.
And if things aren't improving as expected, or if that link between the pain and the original cause starts getting fuzzy, suggesting it might be moving towards chronicity.
This is a really critical point in your sources. You don't just automatically jump up to the next step on the medication ladder. That's the moment to pause, step back, and reevaluate the entire situation through that biopsychosocial lens again. Is something else going on? Are there other factors maintaining the pain? Blindly escalating medication isn't always the answer.
That makes sense. And you mentioned the latter. Steps 1 and 2 are typically used for children.
Yes, that's generally the range considered for pediatric pain management in these guidelines.
Okay, let's dive into the medications themselves then, starting at step 1, paracetamol. Acetaminophen in some places.
Right, paracetamol, often the first choice for acute nociceptive pain that's pain from tissue damage, mainly because it's generally well tolerated by most people. However, and this is a really, really important takeaway from your sources, there are significant safety considerations. The big one is liver toxicity.
Especially with higher doses.
Yes, especially with high doses taking over 6 grams in a single deck, go acutely or chronically exceeding 3 to 4 grams per day on a regular basis. That's where the risk really increases.
And are there specific things that make someone more vulnerable, things that lower that safe chronic dose even further?
Yes, absolutely. Your sources list several important risk factors to be aware of. These include things like fasting or generally poor nutrition, consuming more than 2 units of alcohol daily, taking certain other medications that speed up how the body processes drugs. Enzyme inducers like carbamazepine or phenytoin are examples.
Okay.
Being elderly and frail, particularly weighing less than 50 kilograms, smoking, having certain genetic variations that affect metabolism, already having liver issues, and even combining paracetamol regularly with other pain meds like NSAIDs or opioids.
So the safe dose for chronic use, say, longer than a month, isn't a single number for everyone. It depends on these risks.
That's the crucial insight here. For chronic use, if you have no risk factors at all, the recommended maximum is 3 grams per day. If you have just one of those risk factors we listed, the maximum drops significantly to 2 grams per day.
Wow, just one factor makes that difference.
And if you have multiple risk factors, the maximum recommended daily dose from your sources is only 1.5 grams per day. That's often much, much lower than people might realize, or what might be on the standard packaging.
That's a huge difference, and really important for people taking it long term. What about stomach issues? We usually associate those more with NSAIDs.
That's true, but your sources mention that the risk of serious stomach or intestinal complications with paracetamol does actually increase at doses above 3 grams per day. It's not zero risk.
Really?
Yeah. And interestingly, above 3.25 grams per day, that GI risk could potentially become comparable to NSAIDs, although it's generally considered lower than NSAIDs at doses under about 2.6 grams per day. The exact mechanism isn't fully understood, but it's definitely a risk to be aware of, especially at those higher dose ranges.
Good to know. Okay, moving to step 2. NSAIDs, the non-steroidal anti-inflammatory drugs. These come in when paracetamol isn't quite cutting it.
Right. You've got topical versions, creams, gels, patches for localized pain like a sore knee. These tend to have fewer body-wide systemic side effects.
Makes sense.
And then you have the oral forms, pills, capsules, or even rectal or injectable forms. Now, there's some debate in the study cited about whether they're truly more effective than paracetamol across the board. They might have an edge for specific things like osteoarthritis or acute post-operative pain, but maybe not so much for, say, rheumatoid arthritis compared to paracetamol.
And between different types of NSAIDs, like the older ones versus the newer COX-2 selective ones.
Interestingly, your sources didn't find compelling evidence for a big difference in effectiveness between the different types.
But NSAIDs definitely come with a more concerning side effect profile than paracetamol, generally speaking.
They absolutely do, and this is a major point emphasized in your sources. Gastrointestinal issues, things like stomach upset, ulcers, even serious bleeding are a key concern. The risk seems higher with some like naproxen and ibuprofen, but it's definitely still a risk, potentially lower but not zero with others like TOX2 inhibitors and diclofenac.
And then there's the heart risk, the cardiovascular stuff.
Yes, that's another major concern. Increased risk of heart attack, stroke, and worsening heart failure. This risk appears higher with COX2 inhibitors, diclofenac, and also ibuprofen. Naproxen might have a somewhat lower risk for heart attack and stroke specifically, but the risk of heart failure is present with all NSAIDs. Kidney problems and skin reactions are also mentioned as potential risks.
So choosing an NSAID really needs to consider these risks based on the individual patient's health profile.
Absolutely. Your sources provide some guidance here. If a patient has high cardiovascular risk factors, naproxen is often suggested as the preferred first choice among NSAIDs due to that potentially lower heart attack stroke risk.
Okay.
If, on the other hand, a patient has high GI risk but not high cardiovascular risk, then diclofenac or ibuprofen might be considered, perhaps with protection for the stomach. Generally, though, the COX-2 selective NSAIDs are not recommended for routine use in primary care, according to these particular sources.
And the overarching advice is?
Always use the lowest effective dose for the shortest possible duration. That's paramount because of these potential serious side effects. Don't just take them indefinitely without review.
Right. And there was an interesting environmental note about them, too.
Yes, a small but interesting detail. Your sources point out that NSAIDs generally have a greater negative environmental impact on surface water compared to paracetamol. They pose a higher risk to aquatic life when they get into the water system.
That's a factor most of us probably never consider when taking a painkiller. What about interactions with other medications?
Important ones to know. NSAIDs can increase the blood levels of certain other drugs, like lithium, used for bipolar disorder, and methotrexate, used for arthritis and cancer, potentially leading to toxicity. They can also worsen kidney toxicity from medications like cyclosporine used after transplants.
And the aspirin interaction.
Ah, yes. Crucially, ibuprofen specifically can interfere with the beneficial antiplatelet effect of low-dose aspirin, the kind people take to prevent heart attacks or strokes. So that combination is generally best avoided. If someone needs both, other NSAIDs might be preferred, or timing needs careful consideration.
Good to flag. And for children, or specific conditions like chickenpox or shingles.
Generally, NSAIDs are not recommended for children in primary care settings according to these guidelines, and they're also advised against in patients who currently have chickenpox or shingles. There's a potential, though still debated, link to an increased risk of severe secondary bacterial skin infections in those situations.
Okay, got it. Let's move up the ladder then to step 3, weak opioids. This is when paracetamol and NSAIDs together maybe aren't enough relief.
Yes, this step is typically considered when that combination isn't sufficient, although, as mentioned, sometimes it's skipped entirely in cases of very severe acute pain or cancer pain, where you might go straight to stronger options.
And the preferred choice here is tramadol over codeine.
That's what your sources highlight, yes. Codeine often runs into problems. For one, it needs to be converted in the body to morphine to work well, and a significant portion of the population genetically can't do that effectively, so it just doesn't provide much pain relief for them.
Ah.
Plus, it frequently causes side effects, especially constipation. Tramadol is generally seen as a more reliable option in this weak opioid category.
And tramadol isn't just a standard opioid, is it? You mentioned it has a kind of dual action.
It does, which makes it interesting pharmacologically. Part of its effect comes from its active metabolite binding weakly to opioid receptors, similar to other opioids, but it also inhibits the reuptake of two neurotransmitters, noradrenaline and serotonin, in the nervous system.
So it boosts those chemicals.
Yes, and that action seems to enhance its overall pain-relieving effect, possibly making it more effective for certain types of pain, maybe even neuropathic pain to some extent. For context, 100 milligrams of tramadol is roughly equivalent in pain relief to about 15 milligrams of oral morphine. Your sources also note it's not classified under the Opium Act, unlike stronger opioids.
What are the common side effects people might experience with tramadol?
Nausea and dizziness are quite common, especially when first starting it. These can often be reduced by starting with a low dose and increasing it gradually over several days. It tends to cause less constipation than stronger opioids like morphine or codeine, which is a plus.
Any other side effects?
Less commonly, people might experience psychological effects like sleep disturbances, mood changes, or even confusion or hallucinations, particularly in the elderly. And like other opioids, if you've been taking it regularly for a while and then stop it abruptly, you can get withdrawal symptoms.
Okay. Are there any specific risks or interactions to be particularly careful about with tramadol?
Yes, a couple of important ones. There's an increased risk of seizures. This risk is higher at doses above the recommended maximum of 400 milligrams per day, or importantly, when tramadol is combined with certain types of antidepressants, particularly SSRIs, or some older TCAs like clomipramine or imipramine and MAO inhibitors.
Why that combination?
Because combining tramadol with those specific antidepressants also significantly increases the risk of a rare but potentially serious condition called serotonin syndrome, caused by too much serotonin activity in the brain. So that's a key interaction to watch out for.
Right.
Tramadol also significantly impairs driving ability, so patients need to be warned about that. And dose adjustments are often needed if someone has kidney problems or based on those individual genetic profiles that affect how their body processes the drug via the CYP2D6 enzyme.
Okay, good warnings. Now, on to strong opioids. These are for severe pain, and the idea is to titrate the dose, adjust it carefully until the pain is managed. We're talking about things like morphine, oxycodone, fentanyl patches, etc.
Yes, exactly. Examples include morphine, oxycodone, fentanyl, buprenorphine, hydromorphone, tapentadol. Some of these, like the fentanyl or buprenorphine patches, hydromorphone, and tapentadol, are specifically mentioned in the sources as being registered for treating chronic pain as well as cancer pain.
And a big part of using these is managing the side effects.
Absolutely critical. When using strong opioids, managing the predictable side effects is just as important as managing the pain itself. Nausea and vomiting are common initially and often require preventative anti-nausea medication, like ondansetron or maybe scopolamine patches. And constipation is almost universal with ongoing use and usually requires preventative laxatives right from the start.
Okay. What about this strategy called opioid rotation? Why would you switch from one strong opioid to another?
This is a really useful strategy. You'd consider rotating or switching from one opioid to another if the first one isn't providing effective enough pain relief even after dose adjustments, or if the patient is experiencing intolerable side effects from it.
So you switch to a different opioid hoping for better results.
Exactly. The idea is that individuals can respond differently to different opioids, both in terms of pain relief and side effects. To do this safely, you usually use conversion tables or APS equianalgesic tables to figure out the roughly equivalent dose of the new opioid compared to the old one.
And the sources give guidance on how to adjust that dose when switching.
They do. There are specific rules of thumb mentioned. If you're rotating because of side effects from the first opioid, the advice is typically to start the new opioid at about 75% of the calculated equivalent dose for the first day, just to be cautious.
Okay, start a bit lower.
Right. But if you're rotating because the first opioid simply wasn't giving enough pain relief, then you'd usually start the new one at 100% of the calculated equivalent dose, aiming for better efficacy straight away.
That makes sense. And switching to a patch, like a fentanyl patch, sounds like it needs a bit of extra thought.
Yes, because patches take time to build up a steady level of medication in the body, usually 12 to 24 hours. So when switching from an oral opioid to a patch, you usually need a bridging medication on that first day. This is often about half of the previous total daily oral dose, given as needed, to cover the pain while the patch starts working.
Got it. And does rotation actually help with side effects?
It can, yes. The sources note that switching opioids can be particularly helpful for managing certain side effects. They give examples where switching from morphine to either oxycodone or hydromorphone often resulted in less nausea and vomiting for patients.
Interesting. Okay, let's talk about breakthrough pain. You mentioned this earlier, that the severe flare-up of pain that happens even when someone is already on a stable, around-the-clock opioid regimen, often seen in palliative care.
Yes, breakthrough pain. This requires a separate fast-acting rescue medication to manage those spikes. The general rule of thumb provided in your sources is to calculate a rescue dose that's equivalent to about 10–15% of the patient's total 24-hour base opioid dose. And you use a fast-acting formulation of an opioid for this.
And if the patient is on a patch for their background pain?
For patients on a patch, there are specific fast-acting fentanyl or buprenorphine options available. These come in forms designed for rapid absorption, like oral transmucosal lozenges, sublingual tablets, buccal films that dissolve in the cheek, or nasal sprays. The sources note that using buprenorphine this way might be considered off-label, though.
So if someone finds they're needing that rescue dose really frequently, what does that usually indicate?
It usually tells you that the baseline around-the-clock opioid dose probably isn't high enough to cover their underlying persistent pain. The guidance suggests that if rescue medication is needed more than about 3 times a day consistently, or if the overall background pain level seems to be increasing, you should look at increasing the base around-the-clock opioid dose, for instance, maybe by 50%, rather than just chasing the breakthrough pain with more and more rescue doses.
Unless it's predictable.
Right. The exception is if the breakthrough pain is very consistently linked to a specific activity, like moving or wound dressing. In that case, you might just pre-medicate before the activity.
And there's a very serious warning in the sources about some of those fast-acting formulations, especially the fentanyl ones.
Yes, a critical safety warning. Your sources strongly highlight the risk of serious overdoses, including potentially fatal respiratory depression, where breathing slows down dangerously or stops, with misuse or incorrect use of these potent, fast-acting fentanyl products like the nasal sprays or the oral transmucosal forms.
Oh, careful handling and education are vital.
Absolutely essential. Patients and caregivers need very clear instructions on how to use them correctly, store them safely, and what to do in case of suspected overdose.
Okay. Methadone gets a mention in the sources, but it seems to be a pretty rare choice.
It is, yeah. Your sources indicate it's used primarily in the palliative or terminal phase of care, and even then, usually only after consultation with specialists who are experienced in its use. It's typically considered when other strong opioids haven't worked or have caused unacceptable side effects.
Why the extra caution?
Because methadone has a very variable and long half-life, meaning it stays in the body for a long time, and how long varies a lot between individuals. This creates a significant risk of the drug building up unexpectedly to dangerous levels if the dosing isn't managed very carefully by experienced prescribers.
Right, it requires expertise. Now, shifting to a really sensitive but incredibly important topic, using opioids for chronic non-cancer pain, or CNCP, your sources seem quite cautious here, maybe even more so than in the past.
They're definitely urging significant caution. The core recommendation is to prescribe opioids for CNCP very carefully and only under specific circumstances.
What are those circumstances?
Firstly, the underlying cause of the pain should be reasonably clear. Secondly, other treatments, including non-medication strategies and non-opioid medications used at their optimal doses, should have been tried and found insufficient. It's not a first-line approach.
And it's not deemed suitable for everyone with CNCP, even if those conditions are met.
Correct. A key point emphasized is the advice to generally avoid prescribing long-term opioids for CNCP to patients who have serious underlying psychiatric conditions or a known history or current sensitivities to substance dependence, and that explicitly includes alcohol and tobacco dependence, not just illicit drugs.
Okay. And if opioids are started for CNCP, what's the approach?
What's crucial here is the emphasis on very regular, structured evaluation. Initially, this might be every 1 to 2 weeks. The goal of these frequent reviews is to rigorously determine if the opioid treatment is actually providing meaningful benefit, improving pain and function, and if those benefits are truly outweighing the potential harms and side effects.
And if the pain relief isn't sufficient?
This is important. If the pain relief is insufficient despite dose adjustments, the advice isn't just to keep increasing the dose indefinitely, it's to seriously consider stopping the opioid or perhaps attempting an opioid rotation rather than continuing a treatment that isn't really working well. The potential for harm increases without clear benefit.
Your sources also list specific risk factors that might predict problematic opioid use in this CNCP population.
They do. While acknowledging that the evidence quality varies and screening tools have limitations in primary care, the sources identify several factors that seem to have clinically relevant predictive value based on reviewed studies. These include various psychiatric disorders, things like personality disorders, pain disorders, somatoform disorders, psychotic disorders, mood disorders like depression, and anxiety disorders.
And past substance use.
Yes. A history of substance abuse is a major risk factor. This covers not just prior opioid abuse, but also problems with alcohol, other illicit drugs, tobacco, cocaine, and cannabis.
Okay. And what about the concepts of tolerance and physical dependence? These often get confused with addiction, but they're different, right?
They are distinct, yes. Tolerance means that over time, your body adapts to the opioid, and you might need higher doses to achieve the same level of pain relief you initially got. Physical dependence means your body has physiologically adapted to the opioid being present, so if you suddenly reduce the dose or stop taking it, you'll experience physical withdrawal symptoms.
What kind of withdrawal symptom?
Your sources list things like restlessness, anxiety, insomnia, nausea, vomiting, diarrhea, muscle aches and cramps, sweating, goosebumps, yawning. It's unpleasant, but not usually life-threatening, unlike withdrawal from alcohol or sedatives. Gradual tapering, slowly reducing the dose over time, is necessary to avoid severe withdrawal symptoms when stopping opioids after long-term use.
Is there any benefit to tapering off opioids if someone's been on them long-term for CNCP?
Interestingly, yes. Your sources mention that tapering opioids after long-term use has actually shown some promise in observational studies for improving pain, function, and quality of life in some patients with CNCP. However, they do caution that the quality of this evidence is currently considered very low, so more research is needed. But it suggests that less opioid isn't always worse pain.
That's fascinating. Is there a preferred type of opioid formulation if long-term use is deemed necessary for CNCP in a primary care setting, like long-acting versus short-acting?
The preference indicated in your sources for primary care management of CNCP tends toward long-acting opioid formulations.
Why is that?
The rationale is that they only need to be taken once or twice a day, which can be more convenient and might lead to more stable blood levels. And theoretically, they're thought to pose a slightly lower risk of misuse or addiction compared to fast-acting forms because they don't provide that rapid hit or reward effect. However, the sources strongly emphasize that the individual patient's risk factors for problematic use are likely much more important determinants of risk than the specific formulation type itself.
So the formulation isn't a magic bullet against risk?
Not at all. Careful patient selection and ongoing monitoring are key, regardless of formulation.
Okay, that's a lot on opioids. Let's switch back to neuropathic pain and look at other types of medications used for it, besides opioids, which you said aren't first line. Your sources mention antidepressants being helpful.
Yes, certain types of antidepressants have been found to be quite effective for treating neuropathic pain, even in people who aren't actually depressed. It's a different mechanism of action related to neurotransmitters involved in pain signaling.
Which types are effective?
The types highlighted in your sources as having good evidence for effectiveness are the TCAs, or tricyclic antidepressants. Amitriptyline is a common example, and the SNRIs, which are serotonin norepinephrine reuptake inhibitors like duloxetine or venlafaxine.
What about the more common SSRIs, like fluoxetine?
SSRIs, which mainly affect serotonin, generally lack sufficient research to support their use specifically for neuropathic pain, according to these sources. The effect seems linked to boosting both serotonin and noradrenaline.
So TCAs are often a starting point for neuropathic pain.
They often are considered first line, yes, particularly amitriptyline at low doses. But if TCAs aren't effective for someone, or they cause troublesome side effects, or they're contraindicated for other health reasons, then SNRIs or certain anti-epileptic drugs are usually the next options to consider. Common side effects for TCAs and SNRIs can include things like dry mouth, drowsiness, constipation, and sometimes nausea or sweating.
Okay. And speaking of anti-epileptics, you mentioned them. Drugs like gabapentin and pregabalin are also commonly used for neuropathic pain.
Yes, they are. Gabapentin and pregabalin are specifically registered for treating certain types of neuropathic pain, like postherpetic neuralgia, after shingles, or painful diabetic neuropathy.
Are they reliably effective?
While they can definitely be effective for some individuals, your sources point out that the quality of evidence supporting their efficacy varies depending on the specific neuropathic pain condition being treated. What is clear with high-quality evidence is that side effects like sleepiness, dizziness, and sometimes weight gain or swelling are very common with both gabapentin and pregabalin.
So it's a trade-off sometimes.
It often is, and it's still quite difficult to predict beforehand which specific medication, a TCA, an SNRI, gabapentin, or pregabalin, will work best for any given individual with neuropathic pain. The recommendation often involves a bit of trial and error. Maybe try gabapentin first, as it's often less expensive, then consider pregabalin or an SNRI like duloxetine if a TCA hasn't worked or wasn't suitable.
And just to reiterate, opioids, even tramadol, are generally not considered first line for neuropathic pain.
Correct. Your sources explicitly state that opioids, including tramadol, are generally not recommended as first-line treatment for neuropathic pain. This is mainly due to the typically chronic nature of neuropathic pain and the significant risks associated with long-term opioid use, like dependence, tolerance, and side effects, which often outweigh the potential benefits compared to these other medication classes.
Okay. What about carbamazepine, specifically for trigeminal neuralgia? That sounds like a very specific condition.
It is. Trigeminal neuralgia is a type of severe lancinating facial neuropathic pain. And carbamazepine, which is also an anti-epileptic drug, is the only medication specifically registered for treating this condition according to your sources.
Is the evidence for it strong?
Well, the sources note that the quality of evidence from studies comparing carbamazepine to placebo for trigeminal neuralgia is actually quite low and carries some uncertainty. However, it remains the recommended standard treatment.
Why is that, if the evidence isn't great?
Partly because it has been the standard treatment for a long time and appears effective clinically for many. Also, conducting high-quality placebo-controlled trials for such a severely painful condition is ethically very challenging. Patients understandably don't want to risk being assigned to a placebo group when they're in agony. So despite the evidence limitations, it remains the go-to first option.
Understood. Okay, let's touch on topical agents, things you apply to the skin for localized pain.
Right. Your sources discuss a couple of key ones. First is capsaicin, which is derived from chili peppers. It comes in two main forms: a low concentration cream that you typically need to apply several times a day, and a high concentration patch that's applied much less frequently, maybe every few months in a clinic setting.
What's it used for?
It's primarily used for localized neuropathic pain, like postherpetic neuralgia remaining after shingles. The patch is generally considered second line. An important point is that applying capsaicin, especially the high concentration patch, often causes significant local burning pain itself during and after application, so sometimes a local anesthetic needs to be applied beforehand.
Kind of fighting fire with fire.
In a way, yes. It works by desensitizing the nerve endings over time. Then there's lidocaine, which is a local anesthetic. It's available as a 5% patch. Interestingly, studies mentioned in your sources have shown this lidocaine patch can lead to better patient satisfaction and quality of life compared to taking oral pregabalin for postherpetic neuralgia, even if the pain reduction scores aren't vastly different.
Interesting. And lidocaine also comes in creams.
Yes, creams and ointments. A practical detail highlighted is to make sure you're using formulations that contain lidocaine base for application to intact skin, as these penetrate better. Gels often contain the lidocaine hydrochloride salt form, which is better suited for mucous membranes, like inside the mouth.
Good tip. What are the uses for topical lidocaine?
Besides postherpetic neuralgia with the patch, specific uses mentioned include helping with pain in venous leg ulcers, using a combination lidocaine-prelocaine cream, and even specialized lidocaine eye drops for severe ocular pain associated with shingles affecting the eye.
Okay. Finally, your sources briefly mention cannabis and cannabinoids for pain. What's the overall summary of the evidence presented there?
Based on the systematic reviews and evidence summaries included in your sources, the current evidence for significant benefits like meaningful pain reduction or improvements in physical function from using cannabis or cannabinoids for chronic pain, including neuropathic pain, is generally considered limited and uncertain.
So, not a clear win.
Not based on this evidence, no. While some studies show small effects, the overall quality is often low and the clinical significance is questionable. What is clear is that there is an increased likelihood of experiencing non-serious side effects, commonly things like dizziness, nausea, drowsiness, and dry mouth.
What about serious harms or addiction potential?
The evidence regarding serious harms or the risk of dependence is reported as uncertain, largely because the studies reviewed weren't typically designed to assess these long-term outcomes thoroughly. However, serious harms seemed uncommon in the short to medium-term studies available.
And did they find any evidence it helps people reduce their opioid use, the opioid-sparing idea?
That's a notable point. Your sources explicitly state they found no convincing evidence from the available studies to support an opioid-sparing effect of cannabis when used for chronic non-cancer pain. So the idea that it reliably helps people reduce their opioid dose wasn't borne out by the data they reviewed.
Any other concerns mentioned?
They do briefly mention potential concerns about contamination of cannabis products, although they don't go into detail on the specific types of contaminants like pesticides or heavy metals.
Okay, so a complex picture with limited strong evidence for benefit in pain, according to these sources. Taking a big step back now from all these details, all these medications and pathways, what's the single most important takeaway message from this deep dive into pain?
Gosh, if I had to pick one, I think it's hammering home that pain is a truly complex individual experience. It's just not that simple physical signal we might have thought it was when we started. Especially when it becomes chronic.
Yeah.
It involves these intricate pathways, all this modulation we talked about, and it's profoundly influenced by our minds, our emotions, our lives, our social environment, everything.
And because of that, addressing it effectively means looking at the whole person.
Yeah.
Right? Not just focusing narrowly on the site of the injury or the initial trigger.
Exactly. That biopsychosocial model isn't just jargon, it's the essential framework. Effective treatment almost always requires a tailored, often multidisciplinary approach that really considers all these interacting physical, psychological, and social factors that are unique to that person. Yeah. It's rarely going to be a single solution or a quick fix.
We've certainly seen the wide range of tools clinicians have, from crucial things like patient education and various therapies, right through to this complex array of medications, each with its own specific profile of potential benefits, but also significant risks that need really careful consideration based on the individual sitting in front of them.
Right. It really underscores that treating pain effectively, especially chronic pain, is often a continuous process. It involves ongoing assessment, trying different approaches, adjusting things, and working collaboratively with the patient.
So here's a final thought then. Despite all our growing scientific understanding, the signals, the pathways, the chemicals, the sensitization, what does it truly mean that pain fundamentally is defined by the person experiencing it? It's their subjective report. How does that ultimate subjectivity continue to shape our ongoing and sometimes frustrating quest to find truly effective relief for something so fundamental to the human condition, yet so uniquely, profoundly personal?
That's a deep question, something definitely worth pondering long after we finish this deep dive.